My name is Mike Roberts, and by training I'm a respiratory physician, but in the last 3 years I've moved out of working in the acute sector, and now I spend most of my time working in the community, supporting both a community respiratory nursing team and supporting primary care GPs and practice nurses. The system we're using at the moment for our remote consultations is Teams, and that's because it's approved by the NHS as a secure unit, and because most of our colleagues have Teams installed and are familiar with it. So I think one of the learning is that it's good to have something which is approved by the NHS rather than use a piece of software which is great with fantastic functionality but doesn't meet NHS security requirements, particularly if you're talking about patients, and something which is installed or easily installable in all the colleagues that you're going to be networking with. So how am I finding working with virtual consultations? And I want to really focus on MDTs because that's where I have most experience, and I think it's quite an interesting area to consider. I think they are wonderful, absolutely fantastic. They have lots of advantages over the old system. And with an MDT, for example, it's much easier to bring in a range of professionals into a single meeting for obvious reasons. There's no time spent in traveling. You don't have to find a venue, and people can be working in whatever clinical capacity they wish to up until almost the moment that they dial in to the virtual MDT. So I think that's great. I think there's also an opportunity for people to come together who might not otherwise do so. So, for example, if you're running an MDT with a practice, normally it's just not possible to get everybody into a room together. Sometimes just physically they can't fit into the space. There is nowhere to hold that kind of meeting. Whereas now virtually you can get as many people as you want to into a session, and people who normally might not feel themselves able to push into the room can push into a remote consultation. So I think they've been really, really interesting, really, really helpful, and have expanded the breadth of professional engagement. Yeah, I think there's a couple of things. So firstly, I think it's enabled us to try and form networks that otherwise are difficult to form. So here's a good example. Practice nurses in primary care do most practices do most of the long-term condition management. They tend to be fairly isolated. A lot of practices will have just a single practice nurse. Some may have 2 or 3, and they tend to subspecialize. So in my area of respiratory, there will probably be 1 practice nurse at most who has an interest in respiratory, and they feel very isolated from each other. So now we can pull together an MDT, and we've been doing that for primary care networks. So we now might have 4, 5, 6 practices all on the same call. You've suddenly got 4, 5 or 6 nurses talking to each other in a way that wouldn't have happened in the past. So they start to be able to exchange ideas and views about things, which helps reassure them that there are other people in the same situation, but also it starts a network approach, which means that following on from that video consultation where they've seen the whites of each other's eyes and know that they're all nice people, that the next time there's an issue, they can pick up a phone and speak to their colleague in the practice, which may be only 100, 200 meters down the road, but where previously they haven't worked together in that collaborative way. So I think that's been a really, really, really big improvement that I've seen, and nurses have fed back to me that they have felt that linkage has been a real plus for video consultation. So I think that's been really helpful. Yeah, well, there's a couple of things. So in terms of the future, and particularly for the next year or two, whilst COVID is going to be endemic within our communities, but also because there are lots of positives over video consultation, I see it being part of normal clinical practice for some time to come, if not forever. There is still, I think, a slight reluctance for people to engage in a new way of working. Sometimes it's a fear Sometimes it's a hankering for the good old days, and sometimes it's based on clinical concerns that it's not as good as seeing somebody face to face in the same room, where you can pick up a lot more about body language and et cetera, and where you've got the opportunity for a physical examination. So I think one of the key things is to actually try and set an expectation and an agenda for colleagues that this is the new normal, and you will get to like it because you will start to see a lot of the benefits. So I think one of the tips for me is to engage people in this. If people don't want to engage in it, if they don't feel confident in it, they're much less likely to share meaningful experience or have a meaningful dialogue. So you really, really do need to reassure people that this is the way forward and that it is important, and to share, in a sense, some of your confidence as a clinical leader that whilst there are drawbacks, whilst there are limitations, there are lots of positives in the way that I've already tried to outline to you in this too. So I think that's important. Second tip for me is that if you can see people in the room visually, it's important to take notice of what's going on. And if people look like they're distracted or doing other things, is to try to draw them into the conversation. So by asking people specifically if they have any points to raise or concerns, making sure that everybody feels part and valued. Because one of the things I've noticed too, and particularly this I think is around the hierarchical nature of medicine, if you are a healthcare support worker on an MDT, you may feel more inhibited about participating in an MDT than if you are the senior practice partner GP. So engaging those people by bringing them into the conversation and letting them know right at the beginning, sort of setting some rules, ground rules, I guess, that everybody's expected and is empowered to take part in the conversation, and then bringing them in is really, really kind of important. They're the sort of same principles you'd have in an MDT if it was face-to-face, but I think you've got more opportunities to do that in a video consultation, because you can actually see 9 people at once, whereas when you're in a room sitting in a circle, it's very difficult to actually see what's going on to the people to your left and your right. You're only seeing the people in the limited vision in front of you. So those are some of my tips, I think, about how you need to engage people. Set some expectation at the beginning, let people know this is the way forward, that there are risks, sure, it's not the same, sure, but actually there's some benefits and positives in this, and they need to engage in it, and then proactively bring people into the conversation, make sure that everybody's contribution is valued, and then you're going to get a lot more buy-in to this and more value out of the sessions. I think that's the answer to that's going to vary on who you are and your personality. So for me, I don't find anything hard about virtual consultations at all. I think they're really empowering. In fact, I think with the MDTs, when you've got new people that you don't know, there is obviously something missing in the personal relationship building. But you just have to accept that and work on that by making sure that people have an opportunity to introduce themselves, that you introduce yourselves to them, that you try to diffuse any tensions that there might be, and making sure you involve and engage them in the conversation. So I think it's being aware in advance of that limitation that isn't quite the same thing as being able to shake someone's hand and sit down and talk about the weather with them before you get on with the meeting. But you just need to address that by being upfront and engaging with people. So I think that's the key. In terms of patient consultations, which is slightly different, I think the one area there that's more difficult is you can't physically examine people, but there are some things you can do. You can ask a patient to show you something physically that there is there. You can watch their respiratory rate. You can look to see whether they are looking sick or well. You can ask a patient if they've got devices to measure their oxygen level or their blood pressure, or take their temperature, and to give you that information. And I think the other big positive thing, and there are so many positive things, sometimes I don't think about them all, is to get people to prepare for a consultation. So setting an expectation to say, we're going to have this consultation at 10:20 this morning. In advance of that, would you mind please taking your blood pressure, taking your pulse, taking your oxygen saturation, and thinking about in advance how you've been. Perhaps you've got a diary which tells us about your symptoms. Let's bring that to the meeting as well. And what we don't get is the consultation in outpatient where the patient says, "Oh, damn it, I forgot to bring my peak flow diaries at home with me," because they are at home and they will have their peak flow diary with them. And if they haven't, it's because they haven't been doing their peak flow. So I think, again, lots of advantages over that. And in terms of the MDT, the advantage there is that I think you can give people homework there too. So with our primary care networks, one of the things we've been doing as a CCG is pulling together comparative data. For example, for COPD, what proportion of your patients that are eligible for pulmonary rehabilitation have been referred for pulmonary rehabilitation? And then we can use that as a bit of pre-work for people to look at, ask them to go into their systems, pull out some examples of patients that haven't been referred to try and understand why that might not have been. And then we have a discussion around that at the MDT. And also, if a practice seems to be particularly outstanding in something, we give them an opportunity to share that so that people can feel proud about what they've done and bring that learning together across a group of people in what I think is a much less threatening way when you're not physically in the room together, but you can share that remotely through a video consultation. So huge amounts of positives there. One or two things which maybe are negatives, but I think they're pretty self-evident. You can overcome most of those things. And if you're working in a community team like I am, then if necessary, if you do a video consultation with the patient and they look a bit dodgy, then you can either send one of the nursing team out to see them and examine them, or you can bring them into a clinic area where you've got appropriate protective environment. So you can do those things. It's not that this is to completely replace physical examination. I see it as an adjunct, an addition.